Hey everybody, it's Sean Gibbons from the Communications Network. Lovely to see you on this, I guess it's technically still summer afternoon, and if you're out in California, we're thinking about you. It's really dangerous for a lot of folks out there just now. You are here because you are joining us for a webinar that we're doing. Dr. Richard Wenzel is back with us for the 10th time. Gives you some sense of how long we've all been in pandemic time, to talk about the latest about what we know about the COVID-19 pandemic, the coronavirus that has been spreading across the world. Some new developments that we want to share with you, so we're going to get to that in a really quick minute. My colleague Tristan Mahabir, as he always does, is running the deck. But before we do any of that, let's just do something we do every time that we gather. We've made our practice this year, since it's an extraordinary year. And that is, if you would, go down into the chat box, just with your finger or your mouse or cursor, whatever you got there. Open up the chat box, make sure you're talking to either, we'll say everybody or all panelists and attendees, and just add your name, where you're coming in from, and then 2 words, how you're doing. This is something we've been doing with Professor Brene Brown. It's her idea, the 2-word check-in. And it's okay to be honest. Maybe you got a note from Stefan Lanfer, our board chair, who shared that he's not always feeling it. So if you're not feeling it, let us know, because we can maybe help. But go ahead, if you would, type into that chat box, and I'll do so as well. Hey, Betsy, how words? Mention UV lights. Okay. Catherine, A-OK in Toronto. Suzanne out in Santa Cruz. Be careful over the fires. Yeah, I'll bet, my friend. I can only imagine. Claire in San Francisco feeling smoky. Yeah, Claire, no joke. The particulate matter, maybe Dr. Wenzel can talk to us a little bit about this. Not safe at all. Some of the air quality levels y'all are getting are really scary. Kathy out in New Hampshire, refreshed and rested with grandkids. So that's good. Melinda, resigned and hopeful. Yeah, these polarities, right? Lucille, out in Colorado, very smoky, and you're waiting for snow. Oh, I can't even imagine, my friend. Burtis, fine and okay in New Hampshire. Lauren, tentatively hopeful. Good way to be. Harrietta in Charlottesville, Harrietta, you got fast, feeling fine, but ready for the vaccine, I can imagine. Tracy, how are you? Somewhat depressed. I'm sorry. If other folks can reach out to Tracy, let's help each other today. So you're all in the chat together. Community concern, Jane in Virginia. And Anne, you're in Naples, Florida, I'm assuming, COVID country. Yeah, I'm sorry. Out in Iowa, power outage. Now the power is back. That's good. You all been through a lot with the derecho. Sending thoughts your way. Obviously, you need more than that. I know there's a lot of folks doing some good work there, but you all been through a lot. I know it. Susan out in where are you? In Maryland, Oklahoma, if I got that? Oh, okay. And thankful for Dr. Wenzel. We all are. Susanna, you're getting better. That's good. Kelly, how are you doing? Thinking of others and doing well here. You're in Arlington. Yeah, we've been very fortunate here in DC, but around the country between the hurricanes, the derecho, the horrible fires out in California, it's been a lot. Never mind the pandemic, the racial reckonings. Our friends up in Wisconsin, out in Minnesota, and actually all across the country, whether you're down in Louisville or Atlanta and elsewhere. All right, so let's jump into it. Tristan's got one slide. I got to share one little piece with you. Continue to chat with each other if you would. Hopefully by now you've seen this and you know this. Com Network V, we're going to gather virtually. It's the first time we've ever done this. The great news is it's going to be free, at least for the 3 days that we're going to do. So a lot of the big stuff that we have planned. If you could, we need you to register for that, because we can't let you in unless you register. There's 2 paths we're going to offer you. So one is V, it'll occur September 23rd through the 25th, and you have until September 21st to sign up for that. Go to comnetworkvirtual.org to register, and I'll type that into the chat now. Let's see if I can type here. But that's going to be 3 days, and we just got some really fabulous news today, and that is our friend Stacey Abrams, the former gubernatorial candidate in Georgia. She was with us last year in Austin at ComNet 19. Stacey's going to be back with us. She's actually going to interview Nicole Hannah-Jones, the woman who wrote the fabulous Pulitzer Prize-winning 1619 Project through the New York Times. Stacey and Nicole apparently have never met. They're going to get to meet on stage, or the virtual stage, and have a conversation, which I think will be just endlessly fascinating. So do join us for that. And then we're also offering something called V+. V is free. V+ has a fee attached to it. And the idea there is we're going to gather in small groups of 6, 7, not more than 8 people in community to sort of support one another with some additional programming that'll start before V and then continue into December. So please join us for that. All that information you can find on the website that I just put in there. And with that, why don't I stop yakking at you now that we're all in the room and hand it off to Dr. Wenzel, who's got a lot to tell us. There's a lot that's happening and still more ahead, including how we should start thinking about even next year. So I'm going to pause for now. Dr. Wenzel, sir, please do take it away. And thank you again for being with us.
Well, thanks, Sean, and Tristan, who's behind the scenes. This cover slide just introduces me, and I I want to first thank everybody who's listening and watching, but also put my email down there in case there are questions that come up later that you were not able to get asked. And then finally, to remind me to tell you with respect to names of companies or products that I'll mention, I have no financial conflict of interest. I'm not on any boards or have any stock. Next slide. So I thought I'd begin by updating you on the virus, SARS-CoV-2, the cause of COVID-19 disease. And remarkably, in the first bullet, the full sequence of the viral RNA genome was actually available within weeks of appearance in Wuhan. We already learned very quickly that it was very similar to a bat coronavirus, identifying its likely primary reservoir. We now know that it enters the respiratory tree, but also affects blood vessels on which there are the ACE2 receptors. It causes abnormal clotting and then inflammation. Combined with the clotting can lead to strokes, clots in lungs, kidneys, heart. And again, remind you that in some studies, 10% of the infected people are responsible for 80% of the infections. So if you hear someone say that there are some people that don't transmit, that's consistent with the available data. These are obviously super spreaders, and it makes it much more complicated to control a pandemic with super spreaders. Much easier if everybody spreads it to 3 people than if one spreads it to 200. The spectrum of droplet sizes that contain the virus vary from small to very small to larger. And the very small ones, less than 5 microns, a micron is a millionth of a meter, are so-called aerosols that float in the air. And I keep using this example, like microscopic hot air balloons that encase the virus. And 2 hours later, after the person has even left, who coughed or spoke or laughed or sang, these aerosols with the virus can persist and then be inhaled. Viral shedding peaks with the symptoms. And that means that there have been days where people without symptoms so far have been able to transmit. Although we now know that 40% or so are asymptomatic and will stay that way. We know 2 things about the genetics. One recently, that there's a single substitution of a gene that causes a single change in the amino acid from one from aspartic acid to glycine. It's called D614 gene. This single gene substitution makes the virus more fit and likely more transmissible. And more recently, we've learned from studies in Singapore that a single gene deletion, a small deletion called Delta 382, dampens inflammation, dampens severity, so people are getting infected with a less aggressive virus than previously in that part of Asia. Next slide. So I want to point out that several people are reporting on what so far I would call a theory, a new theory that it isn't just cytokines in general that cause the storm, but particularly one particular chemical called bradykinin. And it's thought that bradykinin is really the cause behind the severe disease, the inflammation. And the way this was discovered was really fascinating, using a supercomputer analysis, the second most powerful computer in the world. The investigators looked at 40,000 SARS-CoV-2 genes and 2.5 billion gene combinations, and it took a week full time for this computer to do that. And what they found was that the virus actually downregulates something called ACE, which actually results in high levels of bradykinin rather than having a balanced level. Bradykinin then leads to leaky capillaries in several different organs, including the heart, the kidney, and the lungs. It also does something else. In the lung, it increases a substance called hyaluronic acid. And as a result, the lungs hold on to more gel in the alveoli, the small sacs, which I'll show you in a second. And as one of the investigators says, it's like trying to get the patient to breathe through jello. ACE inhibitors which are just the opposite of what ACE do, in other words, lower bradykinin, are known to have cough as a side effect, fatigue, and loss of taste and smell. So there's some other biological correlates that said bradykinin may be responsible for the loss of taste and smell. So if you look at the bottom, you see this pictorial of the lung with the lung on the left side, the trachea coming down, splitting into the bronchi, and at the very end of the very small airways leading into the alveolus, the little sacs that you see on the top, it says healthy alveolus. This is where the blood picks up oxygen and dismisses through the air sac for expelling carbon dioxide. And then what happens with a lot of bradykinin, according to this theory, is that not only is there leaky capillaries filling up the alveoli, but there's an upregulation of hyaluronic acid, which actually pours in and makes a gel of the materials there and prevents the gas exchange. And some people think this may explain why it's so difficult to treat patients even when we have high levels of oxygen on a respirator, this gel substance. Next slide. So one of the things I would highlight here is what have we learned from New Zealand, if you will, the poster country for jumping in early, completely locking down and doing just about everything right, limiting, as you can see on this curve, which is a linear number of cumulative COVID-19 cases on the y-axis, and the time from December on the left all the way up to September 7th. And you can see they peaked in late March, early April, at just under 1,200 cases. And then, as you can see on the right, they had 102 days with complete no single case identified. And then after 102 days, they began to see cases. And the genetic sequence was different. What they showed was that the virus looks like had the profile from Australia or the UK. In other words, introduction from outside, not a domestic transmission. And the questions are, was this a failure of quarantine? Did it arrive in cold storage freight? Because in fact, many of the original cases were cold storage workers. What they decided to do was focus the intervention not on the country, but on Auckland, where the new virus was introduced. Similarly, we've seen clusters in Europe and Asia after opening up. And the lessons, I think, are several. One is, this is an unforgiving virus. So even after you close things down, it will appear whenever there's an opening. And I would emphasize, this may be a new paradigm. No matter how you control COVID for days or months, then you might see smaller clusters emerge, requiring more selective interventions and restrictions instead of national approaches. So keep that in mind as one possibility. Next slide. So recently, some economists at the Wall Street Journal are coming around in their own world to saying the same things. You know, lockdowns are very costly. Can we be more selective? And we now know much more than we did in the beginning. And what the authors said, look, we couldn't do what they've done in some countries like South Korea, and I'll come back to that, because we were too late in actually controlling it. So what they can begin by saying, look, COVID-19 lost jobs globally with 400 million jobs lost, 13 million in the US. And the strict approaches were done in China and New Zealand, as I've shown you, very effective. The new thinking is that maybe target restrictions and interventions early. And they base that on the fact that, look, we now know that beginning 40% of cases were all in nursing homes, 16% of clusters in bars and restaurants. Maybe we should have put more focus there if we had done it early. Countries with no lockdowns also had success, they point out, which is true. South Korea, Taiwan, and Hong Kong. And what they did is use universal masks, very aggressive contact tracing, and very plentiful testing. They use masks, which we know to be 40 to 60% effective. And if you look at the testing done in our country, early on, the first couple of months, we had 20 tests per confirmed case. Taiwan and South Korea, which actually had used this approach, had 500 tests per confirmed case. So what the author said is we never did anything on one way or the other. We didn't go completely to lock down appropriately, and we didn't do the South Korea plan appropriately. We didn't have the we didn't have the testing rather, that we needed to be done, nor were we able to do it early because it was overwhelmed, had to lock down. But their point is, maybe if we get this early again, we could actually do selective approaches. Next slide. So if you're going to do contact tracing, I want to point out what I think is a lesson from Native American land. That is the Apaches out in the Southwest with contact tracing that actually saves lives. So the Apaches are infected at 10 times the rate of the population in Arizona, in part, of course, to their lower access to medical care and crowded conditions and poor background economically. Yet their mortality is half of that as Arizona, almost 1.3% versus 2.1% for Arizona. The key when this was written up in the New York Times and also in the New England Journal as a correspondent, contact tracing and the use of pulse ox instruments. As you see on the right, the one you put your thumb in when you go see the doctor, they measure oxygen saturation. And they also got trust because they had Apache speaking team members. So what they said is effective communication and early hospital care saved lives. This is a disease, COVID-19, that makes you very low in oxygen, but for some reason, people don't feel short of breath. You have to measure oxygen saturation. So they combined very simplistic science, went to their houses, became a trusted people. If the oxygen was down in the low 90s rather than high, then they took them to the hospital immediately, treated them, and saved lives. Next slide. So a lot of people ask, how do I interpret a COVID-19 test? And I would point out that there are two reasons why we test people. One for diagnosis. This is ordered by clinicians. And on the right, one for tracking the pandemic, ordered by public health. So if we're talking about patients who show up at a clinic or an emergency room with symptoms that are compatible with COVID, they're in a high prevalence. That is, if we tested them all, a very high proportion of them would have that in the middle of a pandemic with those symptoms. And I'm going to say that probably 60% in the middle of a COVID epidemic with appropriate symptoms like shortness of breath, chest pain, fever, aches, headache, probably have COVID. And their false positives are very low. So a physician in an emergency room says, this patient looks like COVID, but came back false positive, someone else had false positive, it's only 7% if they looked at the non-COVID group. The false negatives though, in other words, this is what I meant to get at first, someone comes to the emergency room, look like they have symptoms of COVID, and just looks like a duck in any other way, 14% will be false negative. But clinicians know that, and they say, I'm going to still treat this patient as though it had COVID, because it just fits. On the other hand, public health, for example, going in a low prevalence area, where you expect only 10% of a random neighborhood to be positive without any symptoms, their false positives, 50%. False negatives, if you have one of those rapid tests, as the governor did of Ohio and found out that he was positive, that was a false positive. False negatives are very low. So if it says you're low, you're negative, you really are negative if you're doing one of the screening in your community. Next slide. I want to point out the good news that really we're beginning to see data on. The advantages of, instead of the RNA Gene PCR test, the antigen, which is a protein test that can be done very rapidly and very inexpensively. And it's fairly accurate, but not as accurate as the PCR. This test, which I'll tell you about, costs somewhere between $1 and $5 versus $50 to $150 for the PCR, even though it's less sensitive than PCR. The turnaround time can be as low as 15 minutes. And as many of you know who have been tested, can be 3 days, 5 days, or up to 3 weeks. The ease of this test, one that I'll tell you about, you spit into a tube with saline, insert a paper strip, and watch for a color strip, almost like a pregnancy test, if you will. Think about restoring the economy. If we daily screen every restaurant worker before they came to work, keep out any positive. We also could screen the customers and say, you're party of 5, all tested negative, 15 minutes later, you come in. If we screened all professors, students, staff at colleges daily, and you can go to school, the rest have to be quarantined. If we screen business employees before work every day, everybody would be in a lot better position. Not only that, but I put a reference in here, mathematical models that looked at 2 times a week using just this particular quick test with the color strip versus every 2 weeks with PCR has a more rapid control of transmission. So it's not only inexpensive, it's effective. It'll bring the economy around. There are now 5 companies working on this, hoping to have this out in the next month or so. Next slide. There's a painter by the name of Peter Schoolworth, who is actually providing these graphic images, what he calls shifted sims, all about COVID-19. We come back and we'll look at this, but what he really wants to convey, in my view, is the disastrous consequences of estrangement. And what the painting does is give forms to being remote as we retreat to N95 masks, hiding in quarantine, surging in online identity, which isn't really us. That is, there's a screen that separates us, either with email or Zoom or others. And so the artist is aware of the computer-generated imagery of avatars, these sims, if you will, the people who are represented, if you are, virtually, but remotely controlled. And if you look at the painting, you'll see next to every avatar somewhere is an estranged double, just as though our lives are split, reality from online on the screen. And the avatars, if you look at the 2 in the foreground, appear to be screaming, unable to convey the gravitas of COVID-19 as though they know something is wrong. They're living a simulation of real life before the pandemic. And I think artists, as Peter Schoolworth has done, whose 20 or so paintings will be shown this week and for quite a while in New York City, is the effects of isolation that we can't always have numbers to tell us about. Next slide. But in fact, there are data on what's happening to us. These are data from the Commonwealth Fund International Survey of over 8,000 people and about COVID-19 related stress on the left and the economic hardships felt by Western populations that are developed countries. And you can look at the countries left to right on the left, and you can see in terms of the percent of people reporting stress, anxiety, or great sadness, the leaders in the Western civilization are the United States at 33%, 26, if you will, in the UK, 23 and 26 in Australia and Canada, and the low, Norway at 10, Sweden, again, the Scandinavian countries. And we may be saying more about what sort of support systems they have, but we're number 1 in feeling the stress and anxiety. If you look to the right, you'll see the report on the negative economic consequences in the same set of countries that are developed. And again, 31% of us in the United States are feeling stress related to the economic consequences. The closest, Canada, 24, Australia, 23. Countries they're very low, 6 and 7%, have a very high level of confidence in the way that their country is being led out of this, in contrast to what's reported in these same surveys about us. So we have a lot of stress. Next slide. And not only that, from studies currently and from prior studies of social skills falling as our interactions decline. I want to show you that there are studies of return of soldiers, polar explorers, astronauts, prisoners who have been very much isolated from society. And it turns out that many of them are anxious, impulsive, they overreact, they're intolerant, they misconstrue what they say, and they want to return back to prison, back to the polar exploring, back to being in space. And Stephanie Cacioppo at the University of Chicago says, this isn't a pathology at all. This is a natural biological response to having been separated and now introduced to crowds. And we miss, she says, the casual contact at work, at gym, even waving to people at art class. And even though heavy online connections, where many of us click and we're proud to have so many likes, might make us feel less lonely. But in fact, Sherry Turkle, who's a psychologist at MIT, said it's actually the reverse. Nobody gets our full attention, and we actually are more separate from them. And what many people say helps is phone directly, talk to somebody, write a real letter, talk to people, write a thoughtful, detailed email that's really personal. Next slide. So I want to show you here update on the international trends, and I'll add one point. These are confirmed cases of COVID-19 for selected countries. And I will point out that you have a log scale going from 110,000 and a million. And what you want to do is have a very low peak and flat. And not shown on here, which would be very low, as you know, maybe 1,200 to 1,500 would be New Zealand. Australia very close, Japan. And then if you go up high in the middle area, you can see these countries that are in Europe, such as the UK, France, and above that, Mexico. And the top three are the United States, Brazil, and what isn't shown here really would actually recently fall in the same line as Brazil's India. So in the United States, we have 6.4 million cases, 194,000 deaths. In Brazil and India, slightly higher than Brazil, has over a little more than 4 million. So it's US, India now, and Brazil, and they're leading the number of deaths. US, by the way, are number 4 in cases per capita, number 7 in per capita deaths. Next slide. So I just wanted to say, look at this slide, which looks at coronavirus infection trajectories. Which countries are seeing the most new cases? So these are new cases. They're average for the whole week. So the leader in new cases is India globally, with close to 90,000 cases very recently in one day, and the US is number 2. Next slide. So look at national trend lines in the US. Again, linear scale on the left, new reported cases by day in the United States, 7-day average. And we peaked at about 25 to 30,000 in April. We controlled things and went dipped down to about 20,000, if you will, in June. And then as we opened up, you can see we were over 60,000 for a while in late July. And now we begin to see a trend down in new cases, but nothing to celebrate at 40,000 on a 7-day average. But we are seeing even a trend down single days though. New reported deaths by day in the United States are on the right. Again, a linear scale going from 1,000 to 2,000 rather. So if you look, you can see that we peaked at about 2,000 a day, late April, early May, controlled things and it went down. And as we opened up and the beaches and the summer, the 7-day average jumped up again and we're about 1,000 for quite a while until just recently we're in the 800s now. Again, still not a lot to celebrate, particularly looking at we are headed for the fall where there's more indoor activity. Next slide. So the question is, why are we doing a little bit better maybe recently? Why haven't we done better? One of the things that's happening is the epicenters have moved from New York to the south, and now not only to the west, but particularly to communities that house large universities. So this is a picture on the left of Big Moose Inn in a small town of Millinocket, Maine, population 4,500. And the title is Rural America, a Wedding in Maine, Super Spreader Event. 65 friends and family attended an indoor wedding recently. And as one and more people said, I didn't see anyone wearing a mask. The next day, one person was ill, and by 3 weeks, 87 cases were traced to that wedding, including those who weren't there, and one death so far. There was some community backlash at the family who felt, people were upset that the family had a wedding and brought in the illness. But rural weddings are a lifeline for communities, particularly small. And one conclusion I would say is, even though the low rates in that community were fairly low for quite a while, transmission may have been caused complacency and the low transmission rate. So you can't drop your guard. If they had had that wedding outdoors, for example, I don't think we'd see this number of cases there at all. Next slide. So now on college campuses, we're seeing all across the country a large proportion of the student body that are positive. And there are two ways that are, if you will, two experiments out there. One actually touted by Tony Fauci on the left, and Art Kaplan, the bioethicist on the right, a different one. So what Tony Fauci is recommending, let the students stay on campus because you'll avoid, sending them home to their community and family where they might transmit it to both the family and community. Opposing that and favoring sending them home, the ethicist Art Kaplan says this would, if by keeping them there, would keep the risk to the staff and professors at high levels if they stayed. And it's more likely to control their movement at home, that it's away from parties and bars and close connections. Well, if you want to have the students stay, my own view would be you have to do the following. Make sure that those who are quarantined, who are found to be positive, stay sequestered environment that's safe, with close follow-up medically, checking symptoms, temperature, pulse ox at least twice a day, and have a rapid pathway to medical health should anyone become ill. Those who are on campus with no symptoms and uninfected should not let their guard down. They should be wearing masks, looking at social distance. The bars in that town should be closed, no crowds. And I think the schools should improve the air inside. That is, how many more exchanges per hour can they do? Can they open the windows and doors? Can they have outside classes? Can they put in both UV lights and HEPA filter to do their best to clean the air? Iowa State recently reported 29% of the students were test positive. University of Iowa, 1,000 cases in the first 2 weeks. And in some days, 50% of the tests were positive. So I lean slightly towards the Tony Fauci side, but only if they're going to follow the recommendations that I would put on the right. We don't know the answer. It's two experiments. We're going to know in the next month or two. Next slide. Now, what about reinfection with SARS? And what I want to put in the title is, yes, it happens, rarely. Now, the background is that South Korea CDC followed cases who were positive for the virus, then negative, and then positive again on PCR tests. And what they found is, while the PCR test was positive, with persistent RNA fragments, there was no live virus after about 9 days. Now, there have recently been reports of second cases. And what the reporters, those who, investigators who reported that say, they have viral genetic change that cannot be explained in the brief time by the usual random mutation rates. So the cases, one that was well documented was in Hong Kong, a 33-year-old man with mild symptoms the first episode. 45 days later, no symptoms, but identified at an airport screen after visiting Spain. And when you look at the genetics of that virus, it was a new virus, not the one seen in Hong Kong. In Europe, there have been two cases, one in Belgium and one in the Netherlands, respectively, and not much more data about that. The US has its first case in Nevada, and the symptoms were worse in the second episode than in the first. So far, it's rare. We don't know the mechanisms or reasons. Next slide. So a little bit about vaccine updates, and just to give you the number of stages, number of people looking at different vaccines. So there are 89 vaccines being tested in preclinical, that is animals and test tube studies, 23 in phase 1 studies. Mostly these are 10 or 20 people max, looking at safety and antibody response. 14 in phase 2, and these are generally 100 to 300 or 400, looking again at safety and immune response. 9 in phase 3 that I've shown you here. Of the phase 3, 2 are messenger RNA vaccines. Remember, those that have vaccine that are basically just the genetic material that codes for the spike protein, hoping that people will get antibodies and preventing attachment. Moderna NIH has one, BioNTech Pfizer has the other. Then there are 3 that have the viral vector. This is where you inject a virus that's adenovirus that has squeezed into it, inserted the gene that codes for the spike protein. AstraZeneca has one, CanSino, and Gamila, the Russian one. And more recently, CanSino and Gamila have published their data, but only on the phase 1-2, showing that the side effects were tolerable and that they did have some immune response. Inactivated whole virus, the Wuhan Institute, Sinopharm, and Sinovac. So 3 in China for the inactivated whole virus, similar to what we do in this country with one of the influenza or more vaccines. There's a repurposed vaccine, some might call this not a vaccine. Murdoch Children Research Institute using BCG. This is a vaccine used to prevent the tuberculosis. Next slide. So the question about, we're assuming that antibodies are a useful part of both prevention and treatment. And recently there was the convalescent plasma therapy, where people who have recovered, have donated the plasma, has high levels of antibodies in most of the samples. And the Mayo Clinic published a study recently. It wasn't a clinical trial. What they did is publish data on their open label, expanded access program, where 35,000 patients have received convalescent plasma. 52% of the patients were in ICUs, 28% on ventilators. So in fact, very ill patients. The 7-day mortality, if you got the plasma within 3 days of your symptoms, mortality was 8.7%, greater than 3 days, 11.9%. So that difference is like about 3% absolute difference in mortality, but it was about 30% reduction proportionally. And what came out initially was the 30% or 35% or so reduction meant people mistakenly took it to mean that of 100 patients, 35 would be protected. Not at all. What the data really show is 3 out of 100 more would be protected. If you got high versus medium versus low antibody titer, the higher the better. 7-day mortality was 8.9, 11.6, 13.7 if you got the low antibody titer. This suggests that antibodies, in fact, are important. And what I want to just, again, encourage you to look at is not only look at the proportion reduction when you read data, but the absolute reduction from the highest to the lowest. And this would be 13.7 minus the 8.9, about 5 percentage points, 4.8. So I would call this a very encouraging study, but there's no control group receiving no plasma, so we don't have solid proof yet. but I'm optimistic. Next slide. There are some studies now on the promising immune response after coronavirus. Initial studies came out and said, you know, a lot of the antibodies seem to disappear after a couple of months. So let me go back in history. In the 1980s, there were volunteer studies in the UK on so-called common cold coronaviruses, those that are named like OC43-225E. 15 people were exposed to that, and a year later, they were recalled and re-challenged with the common cold coronavirus. None of them became ill, but none of them showed an immune response waiting until after the infection really took place, 2 to 3 weeks later. So it looked as though maybe this would protect you against infection, even if you couldn't measure antibodies immediately after challenge. So COVID-19, strong immune response, but how long lasting? Now, if you, just to go through the what we know about immunity in a very simple way, there's sort of 3 steps here. There are so-called B cells, or antibody producing cells, and there's some of them a subset that make early antibody production. And that antibody level may disappear. There's a second type of B antibody producing cell that hide in the bone marrow, and they wait for the virus to return, and they put an outbreak of huge numbers of antibodies. And there's also a so-called T cell response that patrols the body seeking the virus infected cell to destroy it. And what we've learned is reactive T cells found in SARS patients 17 years later still were able to mount a response to that original SARS, presumably should it be seen again. That's very encouraging, that T cell response 17 years later after a similar coronavirus. A more recent study shows robust T cell recognition after COVID-19 in 36 of 36 tested, and also in some not infected. These authors suggested maybe there's even a cross reaction to the common cold virus seen earlier. We don't know that yet. Recently, just on the 1st of September, study reported in the New England Journal confirmed at least 4 months of a good solid antibody response after COVID-19. So these are very encouraging signs about immunity and lasting immunity. Next slide. Now, can you have co-infection with COVID-19 and flu? And the answer is yes. It doesn't seem to be common though. 28 cases that I could find in a literature one study, plus 6 new cases in their reports. The authors screened over 1,100 COVID patients, and 6 had co-infection with flu, 0.54 perception rate. Should point out that the flu test isn't very sensitive, 60 to 80%. So that's probably an underestimate, but probably no more than 1 or 2% at max. A second study looked at 16 cases. 8 of 16 had no underlying diseases, which says that you can have both without any underlying disease. What's unclear is if there's a worse outcome with both viruses present. The finding of COVID-19 in the screen, however, doesn't rule out coincident influenza. So it's very low risk, but you do not want to have flu this winter. You don't want to have flu plus COVID if you have bad luck. So protect yourself. Next slide. What I want to show here is the World Health Examination of steroids for critically ill COVID-19 patients, in which 7 groups of investigators shared their data, each one on a prospective controlled clinical trial. So kudos to World Health to getting them to agree to put together data for a meta-analysis of all 7 studies in 12 countries, 1,703 patients, and use some steroids such as dexamethasone, hydrocortisone, methylprednisolone versus placebo or usual therapy. There was a 34% reduction in mortality rate, absolute difference of 8 percentage points, which is very strong. If you can show on the right, 4 versus 40 versus 32% mortality, And the steroids are effective, they're safe, they're inexpensive. So I think this is a very useful study. Next slide. So looking ahead, just a few comments about keeping healthy. I think we have to try to keep our diet healthy. Try not to gain weight. If you're a smoker, stop it. Continue with some sort of exercise. Try to get your sleep if it's possible. Safely engage family and friends for really emotional response. Continue with your avocations or hobbies. Be sure to get the flu vaccine. You can get it anytime now. No need to wait till late October. And don't drop your guard. We saw what happens when you do. Physical distancing, mask, prefer the outdoors, avoid crowds, continue hand washing. Next slide. So other good news, New York City museums are opening up and we're beginning to see life return a little bit, but with many changes. So the Met, shown on the left, you now have to wear masks. You have time tickets. They're only going to 25% occupancy. Temperature is taken of all visitors. They're down to 2,000 visitors an hour. And knowing that very few people are driving or fewer, they have valet bicycle service. Other museums are opening in the next couple of weeks. MoMA, the Whitney, Bronx Museum of Arts, Brooklyn Museum of Arts, El Museo de Barrio, and Guggenheim by October 3rd. Next slide. So the last slide I want to do is just give you an idea of how I look at things ahead the next year. The fall of 2020, the winter 2021, spring, summer, and fall of 21. So I'm very optimistic that by the beginning of winter, we'll begin to have substantial numbers of doses available. For the first dose of an effective vaccine, there may be more than one. And it'll take a while for people to accept this and get into numbers. And I think we'll be continuing to do first doses out through late spring or early summer. Somewhere between 1 and 4 weeks later, the second dose of vaccine will begin. And I think we'll begin that probably late winter, early spring, and that'll continue, as you might expect, through the fall of 2021. There's also rumors about early vaccines available in the fall, targeted for healthcare workers and high risk. I'm not sure how that can happen given that you have to complete the study and you have to analyze it carefully in a third party. What you're seeing just today was an announcement that 9 companies that make vaccines have agreed they're not going to actually promote the vaccine until they know that it's safe and effective. And it's in their interest that people maintain trust, and it's in the interest of the FDA, the overseer of our safe vaccines and effective vaccines, maintain their trust, and we don't release anything early without having data. I think vulnerable people, unfortunately, will have to continue wearing masks, keep physical distancing, don't drop your guard through at least the next summer. What I'm also optimistic about, though, is if you look at the fall of 2021, that we'll have students in class teaching schools and colleges. Let me, at this point, thank you for your time. Go to question and answers. If people have comments, please go ahead and do them. Thanks, Tristan.
All right, we have a lot of questions. And folks, you can vote for questions. I'm looking at them. If you have a question, please put it in the Q&A box. We've got about 14 now. Go ahead and vote for the ones you want the most. That's how I'm going to follow these. The first one comes from our friend Andy and Dr. Wenzel. He asks, what do you expect to happen with the onset of winter weather and we head into flu season? What's practically speaking, in human terms, what's that going to look like for us?
Yeah, I think with respect to COVID, I would say it's more like forest fires than a wave. We don't want to need to argue about first or second wave. We're having a smoldering in the country right now. We haven't put it out. I think it will rise in the fall to some extent because we'll be going indoors and we'll have the results of opening schools, opening colleges and universities. And I think by definition, we'll see clusters as we already have, not just in Iowa, but in general in South Dakota, for example, and in places across the country with communities of colleges. So we'll see a rise in that. We'll also, unfortunately, somewhere in the fall and winter, see a return of influenza. And so this is the year to get the flu vaccine. So I think those are the two things we're going to see mostly. I've written about the concerns I have for CDC trying to manage those two, plus the mini outbreaks of things like measles and whooping cough, because there's a 60% or more reduction in children and young adults taking those vaccines. And lastly, I don't have to tell you about forest fires or floods or hurricanes or tornadoes. CDC will have to deal with the fact that we may overpower the safe retreats for people as they look for safe places to run from the fires, from the floods and tornadoes. So it's going to be a busy CDC time, but practically we're going to see more COVID and new flu.
So just a question for you. I know that we had predicted months ago now that we could look at as many as 300,000 deaths. We're at 194, tracking it between 800 and 1,000 a day, which means we're perhaps a week or just a little bit more than a week away from 200,000. Give us some context for that. You're a former military, Doc. That was where your training initially came from. I know in the Vietnam War, we lost over 50,000 Americans. Can you create any kind of context for people who maybe you're my age and you don't have a direct memory of that time or anything of its equivalent?
It's really hard for people to get their arms around what it means for 200,000 deaths. Very real. I mean, 200,000 families devastated, holes in their hearts that they really will never be able to patch successfully. If you think about 9/11, we lost 3,000 people that day. And now we're getting up to maybe as many 100 times deaths due to 9/11 in the next couple of months. That's why periodically I try to use art because you can get closer emotionally to the reality. And what a lot of people say who are on the front lines in New York now say, you can't feel this well until you've seen someone on a respirator or worse, someone died from COVID. What's happening is that we're lucky that younger people are now a larger proportion of our cases, but our numbers are still nothing to be encouraged about, nothing to celebrate. So it's very real.
Yeah, our friend Rebecca asks, when talking about relative risk of resuming different activities, I haven't heard much about having someone come into your home to fix something. I think you and I just talked about this before we started. We had a broken oven, so we had to bring somebody in and we cracked all the doors open and disinfected and the rest of it. But where does that fall on the scale of risk? And would it be, are there enough safety precautions that you can take that you can bring somebody in if, let's say, that electrical panel goes out on you, or, in our case, the oven breaks, or you want to bring somebody in maybe to do a cleaning because you haven't had that opportunity? These are all privileged places to be, I understand, but is it safe to do these sorts of things?
Yeah, sometimes you need repairs in your house. And I think that's a common question, been asked a lot. No big studies I could point to, but here's what I would say is, if the worker comes in and you are there and you're both wearing a mask, you cut down your odds very highly. The other thing you can do, and I've been recommending to people, makes you more comfortable, open some windows, open some doors, turn the fans on. And if you're a very high risk person, let's say you have some severe underlying immune problems, probably being outside at that time wouldn't be a bad idea. You also, knowing that the air contain sometimes droplet nuclei, these are the aerosols that hang around for 2 hours, wait 2 hours before you come back into the house. I'm talking about the highly vulnerable person I don't want to take any chances with. 85-year-old grandfather who has some severe immune deficiency on immune suppressive drugs. I would try to protect that person. I would also protect the pregnant person who's at higher risk for severe outcomes if infected.
Related question, well, not related question, but it has me thinking of my almost 80-year-old father-in-law with some health conditions. We just visited with them recently, did the quarantine thing, and then were able to visit with them, which was lovely and helpful, I think, for everybody from a stress perspective. But he and a lot of other people who were in their late 70s remember well polio. And their experience with that told them, I'm not taking a vaccine, even if it's available tomorrow. I'm not going to go first. I'm not going to go 10th. Can you talk to a little bit about that reticence maybe we're seeing from a certain folks in the population, whether it's the anti-vaxxers, and you may have some thoughts about them, or some folks who have direct experience from polio going back to the late 1940s, early 50s?
Well, what happened with some vaccines, even before that, during the war, there was the yellow fever vaccine, and it got contaminated with hepatitis B. It was a disaster. And people remember that occasionally with a live vaccine, not the original salt, but the live one, the virus could revert to a active wild type and actually cause polio. So people have had those bad experiences, and we know with influenza during the influenza in trying to remember exactly what year. I think it was early 70s when there was an increase in Guillain-Barré from the swine flu vaccine. Very low rate, but it was 8 to 10 times higher than the background. So those are things that happen uncommonly. And even with these live virus vaccines, I would tell you that the vaccine with the adenovirus has a defect in it that prevents it from replicating. So that's not going to happen with this adenovirus. However, you know, what I would say is that this is really a big deal of a virus, and the complications are much more than just acute virus. And people are now beginning to form groups that recognize that the side effects 4 or 5 months later are persistent with weakness and headache, shortness of breath, anxiety. And so we're just beginning to talk about that. So unique virus, very morbid. If the vaccine looks safe and effective, and there might be several, each study will have 30,000 people. That's not the million we need to talk about rare events, but I would encourage people to look at the data carefully, and I think take it seriously if most of us think it's good.
Gotcha. Katie asks, and this is related to the vaccine question, there are 9 vaccines that are in stage 3 of testing, but they may be complete at different times. Do you recommend, or do you think doctors should wait until we have the results from multiple vaccines to compare which ones would be best to take with more time, or could we have ones at higher rates of effectiveness versus another? So I think her question is it worth waiting till we have, 4 or 5 of these out in the market, out in the world, before we decide which one might be right for us?
Yeah, it's a complicated question, and I would say if there's a highly effective, relatively safe vaccine, I would want to encourage people to take it. Now you can imagine a situation, FDA says no vaccine will we promote that doesn't have at least 50% protection. So let's say the studies assume maybe they're going to be 8 or 10% of people who get infected today. And now they want to say in the vaccine arm, that's going to be only 4 to 5, per 100. How long will it take before we know the result of that? The higher the efficacy of the vaccine, we'll need smaller numbers, and we'll know that early. So the first vaccines, if they're really good, I would be promoting them. If you get a vaccine that's really borderline, I can understand hesitating to see maybe what the second or third vaccine might do coming along. Might be much more highly effective.
Any of the drugs that seem to be, or vaccines that seem to be in the pipeline that are in stage 3 that you're particularly enthused about? That messenger RNA, I know, is kind of a unique one we haven't seen before.
Well, what I can say is from the phase 2 studies that these make antibodies, these vaccines in general, and several of them have been tried in animals in re-challenge events in animals, and that looks good. And they're tolerable. Remember, the vaccine is given with a booster weeks or so later. And in some of the vaccines, the higher dose was so intolerable that they didn't give a second dose. So you can look at those data. But I think we really would be making a mistake to try to speculate based on phase 2. What we really want to know is if you give it to 15,000 people compared to 15,000 controlled, was it really safe? How safe? Was it really efficacious? Was it 70%, 80%, 90%? Hope so.
Gotcha. So we're in a wait and see mode, I think, is the ultimate answer. We just have to let the science and the data play its course, and that takes time, which unfortunately we have little of, or maybe too much of. Tracy asks, do you think the flu season will be less dangerous since more people are using masks, or do you expect a spike nationwide in both flu and COVID cases coming in the next few months? We talked about this, but what does it look like in a flu season when we are, many of us, wearing masks?
Yeah, if you said, well, taking all flu seasons in general, I would think if we keep doing masks and social distancing, we'll have a lower impact. The other side of that, though, is some years we know that we had 12,000 deaths, other years 80,000 deaths in the last decade where they were counting the same. So I can't predict what the new virus inherently will do, but I think the things that we're doing for COVID will actually mute the impact of the new virus, no matter what it is.
Okay, lots of other questions in here if you've got the time. Suzanne asks, I just had my annual physical. My doctor said there's a shortage of pipettes. So if I had needed something like an STD test, it would have been difficult. Are we seeing a lot of other medical conditions being underdiagnosed and treated because of limited resources going to COVID-19?
Well, I did see that earlier, but I haven't looked at any more recent data. So, I can't really answer that with a lot of questions. I haven't heard anything so much about that. What I've heard from colleagues in Europe, and I don't know that that'll apply for us, is they're running out of testing techniques themselves. And so it takes longer to test people before they release them from the hospital or from under their care based on something. But I don't know the answer to that, I'm sorry to say, for sure, in the United States. I don't think it's a major issue now, or we would have heard a little bit more.
Gotcha. Do you know any new data regarding how COVID-19 impacts pregnant people and fetuses? This is from an anonymous person.
Well, what we know, I don't, in terms of new data, what I know from a study I reported, about a month ago to your group was that the US study showed that it's 50% more likely for a pregnant person infected to wind up in an ICU or on a respirator than a non-pregnant, age-matched 20-something-year-old pregnant person who is not infected. So if you're infected in pregnancy and you really don't do well. Infected, but not pregnant, obviously you do much better. The data from Sweden showed even more concern because their data with the whole population study for a month of childbearing women said if you're infected and pregnant, you have five-fold risk of being admitted to an ICU than if you were a young person of childbearing age, but again, not infected, not pregnant.
Betsy asks, what are your thoughts on UV lights and filters? So something that we should be stocking up on.
Yeah, right now, if you said to me, I want to do everything for my business or schools, I would actually be encouraging people to talk to their engineers, have more air exchanges per hour if they could, try to put HEPA filters in if it's possible, and see if there's a way to employ some sort of UV lights. Because we know that all viruses are killed very rapidly with UV light. And I said the last time, if you look at what's happening in subways in New York, they not only have more air exchanges per hour than businesses or schools. Of course, they're very crowded, tight, small environment, but they're experimenting now with UV lights in the subways. I think we should experiment ourselves very safely. I don't think it's too expensive. There are now a number of machines available that you can get that have combined HEPA filters that you would plug in your room with UV light. Again, no solid data that those new machines will do a whole lot, but I think they're very safe and principles are based on science.
Question also from Betsy says, I would like to travel to LA from the East Coast to see my daughter for Thanksgiving. Many of us have travel plans coming up. What protections would I need at the airport and then also on the plane? What should I be bringing along with me? What should I be thinking about?
Yeah, so knowing the gold standard, of course, for protection would be the N95 mask. And that's for your mouth and for your nose. and you need to wear it properly. If you wanted also to protect yourself from what virus possibly landing on your conjunctiva, you would add some sort of protection for your eyes. And that could be the goggles, and there's some that fit over glasses, others that actually fit right on you that are wonderfully comfortable, or a face shield. So knowing that it could be a crowded flight and you can't control the crowds in the airport, in transition through to get onto the flight, if you wanted to be most careful, I would say from the time you get to the airport inside, the N95 mask or the best mask you have, which might be a surgical mask, plus some sort of protection for your eyes, either a shield and wear it the entire time during the flight. Obviously try not to get up during the flight, but nature calls, try to keep those to a very minimum, and if possible, the window seat.
Our friends at the Phillips Health Ministry ask, in light of the negative impact of the Tuskegee experiments in years past, how do you imagine communities of color should trust the efficacy of vaccines rush through the approval process?
Well, I hope that, what you're referring to is, of course, a terrible part of our history where people were experimenting on given syphilis and observed, not treated. But I would hope that we would have critically acclaimed people examine the data on the vaccine, and then including people of color should look at that and very critically look at, is it safe? Did they conduct the study correctly? Is it really efficacious? Is it to the extent they say? And the message should come from the scientists. If it comes from the politicians, if it comes from the FDA alone, I think that will give a lot of us pause as to how much we can take at face value. We want to hear the message. The country is dying to hear the message from scientists.
Let's talk about that for a quick minute, because you just published an op-ed that stated that right now CDC is not doing its job, or it's not being very effective. It's been sidelined. Can you just speak to that for a quick minute for those folks who perhaps, we shared this email, by the way, if you look in your inbox, chances are you got it, but would you mind just sort of summarizing your thoughts there?
Yeah, what the title of the op-ed was Autumn and the Fall of CDC. And what I've been concerned about is that agency, which usually has led us carefully through other epidemics and pandemics, CDC, has been really sidelined by the White House. And so they haven't been able to really come up with their own data and clearly tell the people the messages of what works and come up with a national plan. And with all the threats this fall, and I use autumn and fall to point out the challenges on CDC. I don't want CDC to be the first agency that's a victim of COVID-19, but they need to really restore confidence in the public health system by being able to be independent of the politics and the personal opinions that may come from outside from many sources. So if you want to read it, it's op-ed in the Hill 2 days ago on Sunday, Autumn and the Fall of CDC.
All right. Our friend Tracy, sort of a related question, asks, will we ever be able to get COVID under control in the US if we don't have a national program to test and trace?
Well, I don't know the answer totally, but I think if the vaccines are effective, we'll be able to control this fairly well. I still think that what I tried to say with the New Zealand paradigm is there are always going to be little bursts for a while, whether it be 1 year or 2 years or so. There will have to be contact tracing led and very serious testing ability for that. If you then say, okay, we're in the fall of 2021, we got a lot of our people vaccinated, hopefully 60, 70%, but that may be optimistic given all the anti-vaccination concerns. But hopefully we'll be there. And then what I think we'll see is just periodically infections. This is never going to go away. It's always going to be there at some level, but hopefully at a lower level, more people will take vaccine, the vaccines will improve, and we'll continue to keep it at a very, very low level.
So you think there's a place in the future where this is more like measles rather than?
Yeah, I wish well, measles, of course, we can, if we wanted to, almost eliminate it. But you're right. Yeah, we could get it very, very low, exactly like some of the other childhood infections, vaccine preventable infections.
All right, so I'm going to take the privilege of the last question because you've been very, very generous with your time. Lots of folks writing to say thank you. Tristan, will you take us back one slide? And so this, I guess, would be my question. This is really worth looking at, gang. And again, we included this in the note that we shared out today. How does this end? And obviously, it's not. The answer is it will never end in a complete way. But to the extent that we can start seeing opportunities to restart the economy and rejoin some of the things that we're currently foregoing. Is that 2022? Is that what that's looking like? What we don't see here is the winter of 2022 or 21 into 22 and beyond. What's that look like?
Yeah. So what I think is we're actually by within a year going to really try to control the epidemic in the United States and hopefully globally, because what we want to control it, the introductions from outside this country. What may help us, and one of the questions earlier about testing, is if we develop the rapid 15-minute test that costs $1, and we do that for a lot of the winter, spring, summer, we may be able to really knock this thing down earlier than the fall of 2021. But it's going to take a coordinated national plan and agreement that businesses, colleges, schools will, comply with this, and in restaurants as well. So imagine that we have testing that's really excellent by the spring of 21 and 2021, and that we have second dose of vaccine easily by the fall. We might, by the fall, not only have schools open up, but we begin to think about, opening up the Met, and we may have levels so low that we'll be talking about, do we need to put masks on if we want to see a play in New York City? Or do we have to then maybe every third seat, but we'll have masks or not? We'll have that debate, I think, in the summer and fall of 2021, if we get the testing right, as well as the vaccine. I think it could be a very exciting discussion.
Well, that is certainly some cause for optimism, and maybe we should leave it there. One final question before I let you go, because I know a lot of folks are starting to think about this, and that is voting. So we have national elections and across the country, regional, local elections happening in just 8 weeks' time, maybe a little bit less than that now. Would you go out and vote in person, or would you opt for a mail-in ballot? What's your recommendation there, if you have one?
Well, I prefer a mail-in ballot. Some people, if you live in small towns, you can actually vote early, sometime late in September is what I've heard. You try not to, I think the vote turnout is going to be high. And I would try to get people to, particularly vulnerable people, in any way to vote early. That's the safest. I think it's a system that could be trusted.
All right, sir, and I'm going to do a little peer pressure here. If you don't mind, would you be willing to come back once again, maybe in a month or 6 weeks' time, just to give us an update? Unfortunately, I think we're still on track to be hearing mostly bad news, but perhaps within a couple of weeks' time, we start to get some of those phase 3 trials back.
Well, Sean, if this is helpful, of course, I'd love to come back. It helps keep me on top of things, and I enjoy the exchanges that we have with the group.
We're having a lot of folks expressing here in the chat. Tristan, I'll scrape this and share it with you, but a lot of folks, Suzanne, Claire, Susan says Dr. W is the best. Maybe that's the best way to put it. But Alexandra says, thanks very much for another great opportunity to understand this disease. Really appreciate that. Lauren's saying thank you. So lots of folks in the chat right now expressing their gratitude. So if you'd come back, we would be grateful. And for now, Karen as well says, thank you, Dr. W. So grateful. Phillips as well. If you wouldn't mind coming back, we'd be grateful to have you. And in the meantime, we hope that you continue to stay safe and well. And we are all very, very grateful for the knowledge and wisdom that you're sharing with us. Hopefully we can all do our best to continue to stay safe and be well.
Thanks, Sean, very much.
All right. Thanks, everybody. Be safe. We'll talk to you again very, very soon. Cheers.
Take care.